This week on the BackTable podcast.
Why would you ever operate on somebody with a BMI of 40 with conventional laparoscopic instrumentation? It just, to me, it's like, why would you subject your physicality to that kind of harshness? Because you know what? We've spent so much time and effort developing our careers and honing our craft. You know, I always, whenever I give lectures about this, I always say, you know, what do things like a Lamborghini and the robot and all these things have in common? They've got maintenance contracts and we take really good care of them. Well, I mean, we have to take good care of ourselves. I mean, the amount of money that was spent, you know, educating ourselves and getting to where we are in our careers, it's priceless. And to replace us if we have an injury is a big deal. So I'm pro preserving your physicality and operating in a way that's very ergonomic.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. And welcome back to another episode of BackTable OBGYN. This is your host, Mark Hoffman, and I've got with me once again our host, Dr. Amy Park. Amy, how you doing?
Good. How are you?
Good. Getting used to the new role, but I think I'm slowly figuring it out. You've been doing what, SGS stuff?
No, I'm reviewing OGS abstracts.
It's like every different meeting you're in charge of all at the same time. So I'm glad we can squeeze this in.
Yeah, I think I've just reviewed. Somebody asked me how many I'd done in the last couple of years. I was like 300 or 400, but I think it's more like 500 to 600, just the number, the sheer number. I know all the techniques for isthmus and things like that. Yeah. So
that's fantastic.
I mean,
well, you're hearing our guest, who is a friend of the show, mentor of ours, and we're excited that he agreed to come on the show. So we'd like to welcome Dr. Arnold Advincula to the show. Dr. Advincula is the Levine Family Professor of Women's Health in the Department of Obstetrics and Gynecology at Columbia University Medical Center, New York Presbyterian, and is the chief of the Division of Gynecologic Specialty Surgery. I think I got it all out correctly. Arnie, welcome to the show.
Well, thank you very much. It's really great to see you and Amy. I know you guys have had quite a following with this BackTable OBGYN. I've heard a lot of amazing things about this podcast, and it's a real honor to be here today.
No, we're excited to have you. We've been lucky to have such good friends who've agreed to come on and share their expertise and wisdom and all that they've done. And you're no slouch for us. So we're excited to have you on to talk about what else but robotic surgery. So we like to start our episodes by having our guests talk about themselves, their practice, and sort of how they got to be where they are. So introduce yourself.
Oh, gosh, yeah. So where do I begin? I mean, how far back do you want to rewind? Do you want to rewind to where I did my residency and kind of how that all unfolded and how I ended up to where I am today?
Absolutely. Whatever you want.
Yeah. I mean, so I did my medical school in Philadelphia at Temple, and then afterwards headed down to Chapel Hill to the University of North Carolina, go Tar Heels, and did my residency there. And I was very fortunate at that time, because in the mid-90s, and I'm dating myself, Chapel Hill was one of the early adopters of minimally invasive surgery, and I think that was very influential in my career. John Steggy, who, rest his soul, passed away recently.
Oh, wow.
Oh, no.
Yeah, he was my mentor, and, you know, I was the first fellow. I'd ask him, I said, you know, I love laparoscopy. He was a big pelvic pain expert, and I'd ask him to take a chance in starting a minimally invasive surgery, sort of advanced laparoscopy, chronic pelvic pain fellowship. And he did, and I was his first fellow. So we sort of like started this whole program, which, as you know, many people, I think, who you've had on this podcast were subsequent trainees under John over the years. He's left quite a legacy that started back with me being the first fellow. Spent a year there. At that time, there were only a handful of these fellowships, and they were 1 year only. So I'm really dating myself. And then my first job out of fellowship was Ann Arbor. My wife was going to do a Robert Wood Johnson Clinical Scholars Fellowship there, and I had to figure out how to find a job for a couple of years. So called around, and serendipity, I I met Tim Johnson and John Delancey at the University of Michigan. And many of you know John is a very famous urogynecologist. And they took a chance on me. They didn't know what to do with a guy who was graduating from Chapel Hill with a year of advanced laparoscopic training, but they took a chance on me because when I arrived at Ann Arbor at the University of Michigan, they didn't even know what a TLH was. Most cases were being managed by laparotomy, like ruptured ectopics. Because remember, this was about a decade after the first LABH was ever done by Harry Rich. And so nationally, laparoscopy was not widely accepted or performed yet in the United States. So I showed up with 3 colpotomy rings in my pocket and told the procurement officer, I'm going to need you to order these because I'm going to be doing TLHs. And their first question to me was, what in the hell is a TLH and what are you going to be doing again? And basically got the job there. They said, take a chance on Arnie, let's hire him, we'll figure it out. And that was in 1999 that I joined the faculty there. And that's where I think where it's all started. I think that's the history that we want to talk about today. That's robotics. I started, I was probably two or 3 years into being a young attending there. And my urology counterpart pulled me into his OR one day and said, Arnie, you got to check this tool out. And I said, well, what do you got going on? And here I am doing laparoscopy in the other room. And I walk in and I see a standard, you know, the one of the very first Da Vinci robots ever sold in the world. I think we either had the 3rd or the 5th robot ever sold in the world. Our hospital happened to get it. Cardiac wanted it, never did a case. Urology started doing prostates, and I walked in there and I sat down and I went, holy moly, I think this is going to transform surgery, especially women's health. And pulled a team together. I was young at the time, so I knew that there was going to be a lot of pushback. So I managed to convince our chief of oncology to partner up with me. And I promised if he had my back, I would teach him laparoscopy because they weren't doing laparoscopic staging or anything like that. So that was the deal. He would have my back. I would teach him straight sticks. And then we started doing cases in 01. And then I was there for 10 years building that whole robotics movement. Went down to Florida for a few years, got recruited to go down there to really kind of build on steroids robotics. And that's when it was really taking off around the U.S. And then in 2014, got recruited to come to Columbia, where I am today, to build gynecologic surgery here. And been here for the last 10 years. So in a nutshell, that's sort of it. But it all really, the magic really began in Ann Arbor. So go blue.
As it usually does, go blue. No, as you know, as Arnie knows, since I lived in his house for a year, I got there right after he left.
He did.
Yeah, no, he's like, they were gonna wait and sell their house, and we had, we're fellows, had no money. He said, we live in my house. I said, I can't afford a real house, and he was very generous and just said, well, what were you gonna pay? And I made up some number, and he said, sounds good. And so we lived in this giant house with no furniture and 2 little 1-year-olds, and it was great. So thank you for that.
It was a huge favor to me because I left in 2009 from Ann Arbor. As you know, that's when the market crashed, the recession was happening.
Yeah,
and we sold our condo in Chicago. I know very well.
So
about the market.
I didn't want to sell my house at the time. So, but I was more than happy. I was a big believer of I was believing paying it forward, and it was great to be able to I knew you had a young family, and I was just happy to have somebody there keeping an eye on things, and so that's why we're all interconnected.
No, and I've got plenty of Arnie's stories too, but you mentioned John Steggy. I just wanted to, I'm just now learning that he passed, and I'm
rest in peace.
Heartbroken to hear that. I think about this show and what made me think about wanting to start it and wanting to do it, and actually John Steggy was one of the people that I thought about and why I wanted to do this show, because I think he was carrying the John Steggy Mentorship Award that you created in his name, was walking back from the auditorium at AGL, and I said, oh, hey, how's it going? Congrats. And I interviewed there, but he was not somebody I knew well, was not somebody that obviously never trained me. I wasn't sure he even knew who I was. And I just said, oh, hey, congrats. And he goes, hey, thanks. How's it going? And you just go, oh, fine. He goes, no, how's your practice? And 30 minutes later, we're sitting down, he just grabs a chair, going through all the challenges, new MIG surgeon in a place where there was a similar story, where there wasn't a lot of the advanced stuff that we were doing, and just gave me an unimaginable, not only piece of advice, but just the confidence to keep going, doing what I was doing. And like, I was nobody to him. I was not, I mean, again, like he's a nice guy, but to sort of stop, like he's holding an award with his name on it. And that's why he had the award with his name on it. I mean, the guy just cared about everybody. And I was lucky to have even that little moment, that little story to have. And it was that moment that I talk about on the show where I think, those little pieces of a conference, the abstracts are nice and the plenaries are great and all that, but like getting to sit down with legends, with people who've done amazing things, and they're always so happy to just tell you what they've done and how to help you. And so I appreciate you sharing that about Dr. Steggy, and it was something that I wanted to make sure that I got to share about him too, because he meant the world to me in that small moment, let alone like all the people he trained and everything else.
I just think back on that time, and I got to Pittsburgh in 2002, and Ted Lee had just gotten there, and you guys are like the founding fathers of like the fellowships there, because there weren't any MIGS fellowships really, like the 1-year ones, yeah, but like at the academic centers, there really weren't. Like Michigan and Pittsburgh are like two, and UNC are like the legacy programs really when it comes to all of these.
Oh yeah, I mean the diaspora, like when the dinners now, like the people
like
that Arnie's
20
trained,
years,
who've trained,
yeah, 25 years,
and like
It's
how
a
many
lot.
fellowships now, how many programs that are like the Arnie disciples, right? That we all, even though I didn't train with you, I trained with people who trained with you. I mean, Arlene was your first fellow at Michigan, right? I mean,
yeah, she was my first fellow. Yeah, it's interesting how it just grows. It's I always believe rising tide lifts all boats, but it's it's honestly it's about opportunity. People like John Steggy, he gives people opportunities. He takes a chance on people. I felt that way about John Delancey when I came to Michigan, and boy, those things are, when they hit right, I tell you, they change people's lives, and I'm forever indebted to these individuals. I honestly don't know what I would be doing if those folks didn't take a chance on somebody who they didn't even know. They're like, who the heck is this guy that wants to come here and do TLHs and letting me do some of the first robotic surgeries in the world in 2001. That was a big opportunity. They could have said, no, this is insanity. Don't do it.
but some of them didn't they? I mean, I think, let's, you make it sound very easy, Arnie. And I think to a lot of us, we look at you and go, man, everything is so easy. But I mean, having been a fellow in Ann Arbor and having, again, you talk about John Delancey, his office is across the hall. I'm not his fellow. The number of times he just like called me in his office to chat and mentor, like you said, but the stories that I heard about what it took for you to go, not only to, say here's laparoscopic hysterectomy, but to take something that had literally never been done. Like it's hard for me to even think about those kinds of things, but talk about, I mean, yeah, you saw it and it was cool, but like the process of actually getting to use an instrument for the very first time in a patient, like, can you just sort of walk us through that? Because I'm sure it was not easy.
No, it wasn't easy, but I kind of I took a pragmatic approach that I felt made sense to me. One is, I mentioned it earlier, you can't go at this alone, then you have to partner with people. So this was a couple of years into being a young attending at Ann Arbor, and I had earned the trust of my chair, Tim Johnson, and my division chief, John Delancey at the time. And then I realized I had to partner with people. And so, like I said, partnering with the chief of G1 oncology at the time, Kevin Reynolds, was really important. Because it's hard when you're young, and I think this goes to all the new fellows who get out there. It's tough to break new ground in an institution where you're the N of one doing it, especially at legacy institutions. And so, partnering with him, and then partnering with some of our best nursing and perioperative staff was tremendous because it's a team sport. So, interestingly enough, when back in that day, there were only a few robots in the United States, and one of the, oddly enough, training centers was Ohio State. So we had to go to Ohio State to train, and as painful as that was, being a Wolverine. And so we went down there with Kevin, myself, 3 of our best peri-op staff. We got trained. We put an IRB in place because it was, although FDA approved for laparoscopic use, it really wasn't approved necessarily for GYN use. And I trained like crazy and studied as much as I could before I ever used it in a patient. So I simulated till the cows came home, picked very, very predictable cases that could be done with or without a robot. And I was very forthright with the patients. You sort of read the tea leaves. You kind of know the patients that would be willing to be somebody to be the first to do something and those that probably wouldn't. And very fortunate enough. I had patients who really trusted me, even though I was really young at the time as a physician. The key was, choosing smartly, not biting off more than you can chew, being able to prove to the hospital, to the team that we can do this safely. Our urologists were taking like 8 hours to do a prostate in the very beginning. And there was so much, low morale and disgruntlement at the time. I picked, my first case was a woman who had large bilateral hydrosalpinges. And I said, this is a case I need to be able to book because, it can be tough sometimes, but my goal was I wanted my team to be able to set it up, complete a case in a timely fashion, and take down the system and feel confident they could do it without any hitches. And second case that same day was TLH for refractory AUB. And that case, again, took me no time to complete. The team was able to set up, take down. After that first day, everybody was so pumped that they could do this. And we did 2 cases in less than the amount of time that urologists were taking to do 1 prostate. And so automatically I got the support of like the hospital. My department was like, maybe there's something real here. We made it scholarly. My chair said, you're not doing this if you're not going to be scholarly about it. So we did that. And then it just snowballed from there. But, it was really just, we had to be methodical and you had to have thick skin. I'll tell you, a lot of people, they said things that weren't really not so nice, right? Even when I was a resident, my mentors told me that laparoscopy was microsurgery for microcephalics. That was the quote that they used to always tease me with.
Oh my gosh. Yeah. I remember that. I remember those days of like, well, first of all, what you're talking about is, I'm going to just reference the book First 90 Days. And I want to just tell our listeners, when you start a new job, it is so important. And what Arnie is describing is so key. Easy wins. You want easy wins. And then just make the team feel like they are a part of something, that they succeeded. Like what you're saying about the morale is so important. And then I remember those days of like setting up the robot and it would just take forever. I was also a resident 2002 to 2006. And then I trained in fellowship 2006 to 2009. And I started doing robotics in 2006 when I hit fellowship. And it would take so long to set up the robot. And then it would take so long to change out the instruments. You want to change out the scissors to bipolar, whatever. It would just took forever. And then the arms would knock against each other. You're right about the team sport. Just even getting the gas, it would run out and you'd be like, there's a needle in that.
Exactly right. Oh my God.
And then, there was just like a million challenges. They didn't have that amplifying microphone in the console, so you'd have to yell. And
oh my God, can I just tell you, since you referenced the not having a microphone, so the night before that surgery, I was so stressed. My first case, right? This was back in the fall of 2001. And my chair said to me, he goes, we're giving you a lot of latitude to do this case. And Mark, Tim Johnson, so he can sometimes say some things that could be a little bit out there. And I'm not going to say it on the show, but he basically says to me the night before, he goes, don't F this up, Arnie, or it could be your job and your career. And I was like, oh my God, I'm not going to sleep tonight. I went home that night and told my wife, I'm like, oh my God, we may be homeless after I do these cases tomorrow. But I went, and I don't know if people know, I don't know if there's even Radio Shack anymore, but I went to Radio Shack that night because I knew there was a communication problem, right? We couldn't hear in our OR, if I'm on the console talking to somebody.
Yeah.
So I bought 2 walkie-talkies and I jerry-rigged them as an open line with one taped to the console and another one hanging off an IV pole next to Kevin, my bedside assistant, so that we could hear each other because we couldn't hear.
That was serious. That's like that is a whole field of human factor. Like Jen Anger has done some really great work on that, but you could not hear. I remember I'd be like, stitch, 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 and you couldn't really hear anything. And we're dating ourselves now, but I love that you jerry-rigged it. And then I also remember all the disdain towards laparoscopy. Again, dating myself. People did not get what Ted was doing at McGee, and they were not into laparoscopic sacrocolpopexies.
Yep.
They didn't understand robotics. And now, there's just been further iterations of the robotic technology. The teams are so much better. I mean, the nursing teams. I mean, just the whole process is so important. I remember you were doing courses, Arnie, about like, yes, the surgeon part, but also the team. You were always big on having an aspect of training your team. So you'd always have a segment in your courses about training the peri-op robotic team and setup and everything else, because keeping that whole octopus, sterile is quite a feat. And then just the derision. But I will say, at least you're a straight stick surgeon, because quite frankly, I don't know, and this is a very spicy statement, but urology now has gone the other way, and they don't have the straight stick skills. And so you have to have a robot in order to lure and recruit a urologist.
I think that's probably becoming more true for Urogyn too, though. I think and for a lot of us, and so Arnie and I bumped into each other at a meeting in Vegas a few weeks ago. I was talking to a general surgeon who runs the ORs in a big hospital system around here, and said he can't hire general surgeons. They have to have robot access. Even the general surgeons now, they are, and many of them, dependent in a way on robotics, which is, not a bad thing. It's just how much it's changed. Because I watched, and I'm trying to think if YouTube was even a thing, but it was like the videos I watched online as a med student in Kentucky, where there was very little, advanced laparoscopic surgery, if anything at all. Watching videos of Arnie. I watched some of your very, very first videos, and I wrote my letter for residency saying I want to be a minimally invasive surgeon. And I matched at the University of Chicago, where my program director said, I realize you like minimally invasive surgery, but we don't. And she said, if you want to do some, good luck. And so I had to make a box trainer in a closet myself and teach myself how to operate laparoscopically. And because if I ever got a case, I had to make sure I did everything possible for them not to convert, because they're so fast to go, it's too hard. But if technically I could do what they wanted to do, they knew the surgeries, but I could technically do what needed to happen to keep it going. It increased the number of cases I got to do. But they had very early robot cases, and like we all hear about these robotic disasters, and they had them. It was these long cases in 8 hours, and injuries and these things, because I think it was people who weren't laparoscopic surgeons who didn't understand the techniques of laparoscopic surgery. And the reason why I imagine some of the urology cases were 8 hours, but your TLH was, our robotic surgeons here, like within the last year, weren't allowed to do 2 cases on the first day because of how long it takes them. Whereas you're doing 2 cases on the same day for the first cases ever. It's mind-blowing.
He is right, though. It's about choosing the right candidate. And I will tell a little story about my humble pie. I tried V-Notes, and I was like, you know what? Not to brag, but I'm a pretty good vaginal surgeon, right? So I was like, well, I'm going to look these cases that I can't really do vaginally myself. So this one that didn't have much dissensus, she, of course, turned out to have endo. I couldn't get it.
That's Murphy's Law.
Yeah. And then the other one was like, it was another thing that I had to get the ovaries, but it was like some sort of thing. And, no, she had a high BMI. That was what it was. And so I was like, I'm going to do these cases. And you know what? You do not want that on your learning curve. That's like when you're varsity. When you're frosh off, you just got to be like what you're saying, choose the right candidate. And that goes for any kind of surgery. It's like that. Nobody knows this song anymore, but that Kenny Rogers song, it's like, you got to know when to hold them, know when to fold them, know when to walk away, know when to run.
I quoted you, Arnie. We talked about this when I was starting at Kentucky, and you said, do yourself a favor. I don't remember the exact words, but it was, don't be a cowboy. Like, you're going there, you're new. Like you said, in the sense today, take your easy wins. Don't do things. Don't be aggressive and do things that cause people to lose their trust in you. And so I think it's a very slow curve. And I think some people are like, oh, he can't do stuff. He's, it's slow. But ultimately, like 12 years later, there's nobody doing stuff that we do for, 80 miles in any direction. But we were able to build a program because we had good outcomes, because we had people in the OR who looked over and go, oh, they're doing interesting things. And I've got a tech now that I've been working with for a decade, who's a close friend, who saw value, saw the potential in what I could do. And it was just, everything became fun after that. And so finding those partners who see what you're doing and jump in and go, I'm going to be a part of this because this is awesome. And that's been the joy of my job, is building those teams.
So can I just ask, when you sat at the console, Arnie, I mean, you're a skilled laparoscopic surgeon at this point. What about the technology really attracted you and made you think, I'm going to switch?
What I saw immediately was that it was going to take components of procedures that are difficult to do by traditional laparoscopic instrumentation and make them much easier. The caveat is no matter what, you have to know how to do a procedure. You have to know the steps. You have to know how to operate the fundamental, like the key principles of exposure, dissection, anatomy. But the first thing that hit me was like, oh my God, this is going to be transformative for things like myomectomy. That was one of the first things I thought, because that's so labor intensive to do, multi-layered suturing and things along that line. And, that was when we didn't really have barbed suture yet, and so it was like, so I was doing, the early days of doing even robotic myomectomy when we did some of the first cases in the world, it was with traditional suture. That's what I saw immediately. And then as I let it marinate a little bit more, the other big thing that really hit me as I was sitting at that console and then subsequently getting trained and then doing those initial cases was that I felt this was going to democratize minimally invasive surgery. It was going to make it more accessible by a larger number of people, because there are a lot of skilled surgeons out there, and there's nothing wrong with leveraging technology to make that experience of surgery better for you as well as for the patient. And so, to me, it may sound a little bit controversial, but I don't think you need to know traditional laparoscopy to be a phenomenal robotic surgeon, because robotic surgery is laparoscopic surgery. You are using, if you're doing intracavitary surgery, you're using an environment where you have insufflation, you have access to cavity, you have to know the same principles of energy. All those things are no different. You've got to take adhesions out, you've got to put ports in and gain peritoneal access. The difference is that it's just a tool set at the end of the day. So instead of using like a ultrasonic device to do your dissection, you're using a tool that's on arms articulated and you're sitting remotely. But it's essentially, when you look at the screen, it's a laparoscopic environment. So, to me, that's why I feel like these specialties like urology, like colorectal, for example, that traditionally have been open are they're bypassing laparoscopy because they're learning laparoscopy at such a higher level, and they're skipping the parts that were very painful to have to live through. So I don't, to me, when people say, oh, you do robotics, you do it straight, it's all laparoscopy. It's just that there are those of us who choose a very specific tool to accomplish the laparoscopic MIS case.
It would be like saying you have to start laparoscopy without a camera first and stick your eye to the camera, because that's how we did it back in the day. And like at some point, like, no, guys, we have newer tools. You can just skip to the best tools that we have now. Because I think for a long time it was robot versus laparoscopic, and I think it was maybe Jan Anderson or somebody was like, it's an instrument. We can talk all day about this, but at the end of the day, as the technology develops, over time, it's going to be ubiquitous. It'll just be in the OR. So, but I think that takes a vision to see that, right? To see a computer the size of a city block and go, no, this is going to be on your wristwatch in 50 years.
Well, but let me just play the devil's advocate, because I just read this Facebook thread on the secret OBGYN group. I guess I'm outing them now, but basically people were like posting about the fact that this rural hospital cannot recruit physicians because they don't have a robot, and so it's like they can't do it without the tools. So like, what's happening now? Obviously there's a lot of other things going on. There's DOBS that came up into the conversation for the generalist. We all work at these tertiary care centers, big academic centers. What does that mean for like the community hospital in a small setting? I know last episode we talked about the click and pay, whatever, as you go.
Pay per click.
Yeah, pay per click kind of a model. But like for these small hospitals where the margins are really thin, government payer mix, like, are we restricting access for those patients to MIS? Because they can't do the surgeries?
Yeah, no, I know what you're getting at. But, if you really deep dive, think about this. That is absolutely the place that you want to put a robot. Because in a rural setting where you are resource restricted from personnel, for example, that's where, for me, you put a robot in a rural setting where and there's going to be patients, there's going to be a catchment area, and often these patients have significant pathology. I'm going to be a happy camper because I'm going to be able to do those cases more autonomously, because that's the other piece I think people forget that the robot brings to the table is this level of autonomy that doesn't exist in any other way that platform that we operate on. You know, I train my fellows to be able to do cases basically by themselves. I show them, I demonstrate on a daily basis. You can go in and you can do a myomectomy by yourself. You know, you go in there, you prep the right case, you prep it correctly, you got good technique. You know, you put your ports in, and once you dock, you know, you can put vasopressin in that uterus before you sit down. You can preload your suture. If you have good technique, you don't need much suction, and there's a suction that's built onto the robot if you want to do that. And you sit down and you got a positioning system between the legs to hold your uterus in place. You can do that surgery pretty independently with very little need for an assistant short of an instrument-guided exchange. And even if your assistant can't do that, give me a sterile glove and I'll just do it myself. So I just think that in that type of setting, I think it's, you know, people get into the cost piece and everything else, but it's a complicated discussion. But it's also about like how you set up. You know, if you don't think about like what instruments you're using, what your setup is, like that, all those things do add up if you're going into it blind. But if you, and the thing is, it's so evolved nowadays, right? So it's the robotic technology has been around for over 2 decades, and so it's not like there aren't roadmaps for how to do this, and people don't need to reinvent the wheel. There's different roadmaps that apply to different scenarios and settings. So, you know, I just don't, I agree. Like it is important to have that technology there. It's like having got to have like a defibrillator. You've got to have like an MRI or some sort of scanning, CT scanner at these places to do some imaging. I think this will allow people to be able, whether it's general surgeon, a GYN, a urologist, people to be able to manage some things instead of having the patient who then can't even go somewhere. Like if they can't get it there, sometimes they won't even travel. So they just don't get any care at all. So it doesn't necessarily mean that they're going to, go somewhere else and get the surgery done. So I don't know. I mean, others can disagree, but I just feel like it's a tough question to answer, Amy, to go back to what you were asking. But I would say that I don't blame the hospital.
I'll say my thoughts evolved on this. I mean, I think there's been, as I've been in Kentucky and I've gotten to work in a small rural hospital, like part of, we used to run a practice in Hazard, Kentucky, Perry County, Kentucky, Appalachian Regional Hospital, and recruiting a MIG surgeon down there. Are you kidding me? Like, they need someone who can do it all, who can deliver babies, who can do primary care, who can do gynecologic surgery. And one of the things that really changed how I thought about healthcare in general was about access. I saw a patient down there in clinic, needed a more advanced thing, needed actually Eurogyne, which I didn't do. Come up to Lexington, it's 2 hours away. I said, well, they couldn't possibly do it. Well, what do you mean? I mean, no, I did the drive this morning. I'm doing it this afternoon. And they just didn't get care. They would not leave. They wouldn't get care. So having somebody there, and, a lot of the general OB/GYN residency programs who don't have MIGS fellowships or MIGS surgeons or have strong MIGS volume aren't coming out being able to do complex laparoscopic surgery with traditional laparoscopy and are much more comfortable in the robot. So I've seen it. I think saying, oh, they're putting a robot in these little hospitals, the patients are actually going to be the ones who convert. If they come to me and I got a robot or not, they get an MIS case. I've done hundreds and hundreds of cases in 12 years. I haven't converted in over a decade. They're going to get a TLH. In those communities, the robot is the thing that will allow them to get a minimally invasive surgery. And so I think, yes, it's expensive, but compared to abdominal cases, compared to inpatient stays, compared to with all the comorbidities and obesity and infection and readmission and long-term stay and wound and all that stuff, like that's where the impact, I think, is actually probably the biggest with these kinds of things. And so, like you said, democratizing laparoscopic surgery, I'm seeing it in these with the biggest impact in these smaller hospitals. And so I think it's actually like, Amy, where you are, if the robots all stop working, you guys are all going to do laparoscopic surgery. If they stop working in those hospitals, they're all getting open cases.
Yeah, I see what you're saying. I just I think it's super interesting. Like, it's an enabling tool, but without it, we're not enabled, is also the other side of it.
What if the monitor breaks for a laparoscopic case? What if what if your bipolar machine breaks during the case? Like, it's all technology. I mean, yeah, it's bigger, but ultimately, like, we're all dependent on, I've been in the OR during a power outage. It's just scary.
Yeah, no, I know. And Epic, when it goes out, it's like, it's debilitating. Oh. We had a little outage for like 2 hours, and I was in clinic. Thank God it only affected one patient or two patients, but like, people were freaking out. So I understand that. So Arnie, I just wanted to get your like arc of history perspective. Like, where do you foresee robotics going? Because I mean, I've been around now for the last 20 years, and I've seen the widespread adoption of robotics across multiple fields. I think gynecology and urology especially, but now, colorectal, general surgery, doing Whipples, bariatric surgery, whatever. But, what do you think? Like AI, are they going to have some autonomous motions, like a car to help you with anatomy? Like there's fly technology. What are your thoughts?
Well, I mean, to be honest with you, to me, just to go back to some stuff we were talking about earlier, it is just part of the evolutionary process, right? So this is just part of I'm not splitting any hairs. It's all MIS, laparoscopy, straight stick laparoscopy, robotics. It's all MIS, but it's evolutionary, right? So things are just evolving. Where do I see it in the future? I don't think we can get any less minimally invasive. I mean, everybody does a pretty darn good job. I mean, we're doing keyhole surgery, for crying out loud. But what's really going to be the change is the digitalization of the way we operate, the computing power that's going to drive what we do, the decisions we make in surgery. So if you think about it, instead of becoming more minimally invasive, we're already minimally invasive. What we're getting is we're just going to be smarter MIS surgeons. We're getting really good actionable intelligence to help us make decisions intra-op. That's really where robotics is going. It's digital. Yes, there's going to be some component of AI, which I think scares people, because I think we're all learning now what AI is and what the implications can be. I mean, I still think at the end of the day, we're not going to be replaced by a robot. You still need the surgeon there as the core of this surgical experience. But it's about just being a smarter surgeon, being able to, as you referenced, Amy, be able to have the ability, our cars are smart, right? Our cars have lane assist guides, and they tell you when you're veering off, and they let you know when there are cars around you and pedestrians around you. To be able to have that built into while you're operating, you're knowing that you're near critical anatomy, being able to integrate your imaging, modeling your MRI into the operative field. That makes us smarter while we're intraoperatively doing a minimally invasive case. That's where robotics is going. So I honestly believe, and I feel like, knock on wood, my intuition has been very good these last 20 years and throughout my career. I really believe that we're going to get to a point where, no patient's going to have a laparoscopic procedure that isn't on a robotic platform. It's the same as saying I'm not getting into a car that doesn't have airbags and a seatbelt and power brakes and power steering, right? Anti-lock brakes and power steering. I mean, you can get into a car without those things. Good luck if you get into a car accident. I just think that from a robotic standpoint, that technology is so quickly evolving that it's going to get to a point where when you go into the room and you say, well, I'm going to do your surgery, they're going to say, well, how are you going to do that? And if you say it's not on a robotic platform of some sorts, they're going to be like, what do you mean? Because that's it's just going to be actionable intelligence, right? Things that help you make smart decisions intra-op to really take that surgery to the next level, and the outcomes and the experience for both the surgeon and the doctor. That's something I really, truly believe.
I think the car analogy is the right one, and that's the one I've used. We don't have self-driving cars today, right? But we have, like you said, lane assist, right? There's little tiny pieces of the whole that you get. First, it's the car in front of you stops. My car stops for me, like faster than I can. And you go, oh, that was a good thing. They stopped. My goodness, my car just saved me from an accident. And you go, that's kind of nice. And then you get comfortable with that. And then you go on the highway, and the lane keep assist is kind of nice. You're not, worrying about veering off a little bit or whatever. Like if you get in the next lane, it kind of reminds you, hey buddy, put on your blinker. There's all these little things that you go, actually, this is nicer than just me driving. I thought I was great, but honestly, and I have a theory, I don't think it's a crazy theory, but I think with Hub and what's going on with Da Vinci and AI software, we're teaching the robots how to operate. I mean, I think we are showing them, how would you teach an AI how to operate? You would show them millions of surgical videos, and Intuitive's got their AI software watching us operate. Now, whether or not they're going to do the surgery for us, the same way the cars, in a sense, could drive, but they're going to be like, hey, like buzz your hand when you're near the ureter. Like, hey, buddy, you're right on the uterine artery, like heads up, or, you're getting close to the bladder, or whatever that little But it'll start with that, right? Which it's already kind of getting there. But with the haptic feedback, it's going to be a little bit of a buzz or a warning or to remind us of these critical structures that will eventually allow us to get more comfortable relinquishing piece by piece some of the steps. And ultimately, the decision for surgery is one that is the relationship between the patient and the physician. I think we're a long way off from that, right? So I don't think we're out of the thing. But ultimately, this physical steps of the surgery, I think I can see how that would evolve over time, sort of piece by piece, like with our driving.
But can I tell you the one thing that really excites me a lot with the new technology, and I think everybody knows that Intuitive released their latest platform, right, the DV5, is the case insights that we get from using the robot. So you mentioned that we're going to be teaching robots how to operate. I think it's also the other way around. The robot's going to be helping us learn how to operate better, because to be able to get access to your kinematics, the way you move, the way you operate, and then to be able to take that and marry that with your surgical case, your video, and then ultimately your outcomes, it's going to be a way for us to really kind of streamline in a more nuanced way how we train, right? I mean, I think we all know, we watch people who do a TLH, right? And they're those ones that are done very elegantly, and you're like, wow, if I was a patient, I'd want that surgeon operating on me. There are other ones where, the TLH was completed, but it looked like it was trying to choke down a tough piece of meat, right? Like it was just really wasn't the prettiest thing that you're looking at. And I think we all know that, sometimes those outcomes are tied to the way these procedures are performed, right? And so to me, being able to understand, so if you know that there's a really ideal way to kinematically be using the robot and how you operate, manipulate your instruments is going to bring you a better outcome. And then we can use that as we teach and train. It's going to be amazing. And I think it's going to give us the kind of objective data that we need as surgical educators to take training to another level. Right now, the way we graduate people is, we observe them, we check boxes, we say, yeah, they did X number of cases, looks good. A lot of this is subjective, but to be able to now have true objective data to say, you know what, your performance on the robotic platform are not at the level that we would consider mastery yet or a proficiency, it really then brings to question then what, we should now be going towards proficiency-based progression training and how we now graduate maybe residents or fellows or new docs trying to learn a new procedure. It's a heavier lift. It's tougher when you go down that road because there's a lot more stringency to that. But, it's a patient at the end of that knife. And, if we want to have the best surgeons out there, I think we need to elevate how it is that we assess and train. And I think the robotic technology is going to give us the tools and the power to be able to do that. That's the part that excites me the most. Like I said, I think we're pretty damn good at minimally invasive surgery. I don't know how much more MIS I can be with the little keyhole incisions I take, 1 kilo uteri out of. But I think it's that computing power, that the digitalization of what I'm doing is what's going to be the next transformation for me, which I'm excited about.
Yeah, I do hear you on the advancements in both the technology and also the competency-based learning and assessments, because right now you are right. It's an imprecise science, and educationally, how do we assess that in an objective manner? And it's hard, And I also think that the other thing that people are raving about is the ergonomics of the new platform. I have this interest in surgical ergonomics, but anybody who's been in this business for a long time has an interest in surgical ergonomics. And, I just saw something. It was from Mayo because Sue Halbeck is there, but they looked at the ergonomic strain, and for robotics, it's less than the other modalities, which I think makes sense. I mean, people have to make the effort though, and more expert surgeons are better at this. Just like I'm better at coaching the trainees. Hey, when you're doing vaginal surgery, a little more Trendelenburg, table up a little bit more, table down. Little things like that make a huge difference for exposure, etc. But I think that long-term preservation of our careers and longevity of our careers, people are raving about the new platform. It's much more ergonomic than before. And I think that there's all this emerging data showing, before the data were suggesting that the ergonomics were better for robotics as opposed to conventional laparoscopy and open. But I think it's anecdotally definitely been the case. But you guys are long-term, high-volume, straight stick and robotic laparoscopists. It's, what has been your experience with the two?
Well, I mean, I was just going to say that I don't really have any physical ailments, short of maybe a little too much bourbon here and there. But other than that, I don't have any physical ailments because I've literally operated on a robotics platform since 2001. So I do all my really lengthy or complex laparoscopic surgery is done with robotic assistance. And so from a ergonomy standpoint, I've just I just look at people like, why would you ever operate on somebody with a BMI of 40 with conventional laparoscopic instrumentation? It just, to me, it's like, why would you subject your physicality to that kind of harshness? Because you know what? We've spent so much time and effort developing our careers and honing our craft. I always, whenever I give lectures about this, I always say, what do things like a Lamborghini and the robot and all these things have in common? They've got maintenance contracts and we take really good care of them. Well, I mean, we have to take good care of ourselves. I mean, the amount of money that was spent, educating ourselves and getting to where we are in our careers, it's priceless. And to replace us if we have an injury is a big deal. So I'm pro preserving your physicality and operating in a way that's very ergonomic.
We've seen surgeons and we know surgeons that have had injuries in the OR that have prevented them from operating. And Amy and I have had an episode at least on this. I came to Kentucky when there was one robot, and it was at a different hospital from where I operated, and it was really difficult to get over there. And I actually had about a 7-year break. I mean, again, when there were 6 robots in Ann Arbor, it was just like we had it in the room whether you use it or not. And I had to convince my faculty to let me do some straight stick cases because I was worried about where I would end up in the robot access. And so I took a 7-year break where I didn't do a robot case. And last year I retrained, got back on the XI, and it's just so much nicer. It is just like stick shifts are cool, but like an automatic, it's just nicer and easier, and there's just more comfort and dual console and teaching, and like there's so much about it that is just easier. And then I'll do myomectomy, like you said. That's the case where I was like, all right, way to go, Mark, you can do a straight stick myomectomy, but who would ever want to do a straight stick myomectomy if they had a choice? It is such.
Yeah, I mean, I don't know.
No, I've done them.
I'm straight stick though, and I love doing my sacrocolpopexy straight stick. But I just love it. Like, but myomectomies, I acknowledge it's a lot of sewing and it's a lot of layers
and it's angles. And it's you don't always get.
It's very angled.
You don't always get a vaginal cuff closing the same way. You've got vertical and diagonal the wrong way, and you're just trying to push this way and that way, and it's like. You get it all with the robot. It's just boop, 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 boop. It's so ergonomic. It's so intuitive. It is the case to me that really, and you said it, Arnie, it's the case that really is made so much easier with the robot.
Yeah. I think one thing that maybe the listeners hopefully will take home from this is, like I said, it's part of the surgical portfolio. It's like part of our surgical armamentarium. It shouldn't be one or the other. It's just surgeons choose what they like to use, right? And nobody should think one way about somebody. To me, I think that's part of the problem through the years is that people have sort of pitted things against each other and, looked upon people a certain way if they did or didn't do robotics or did or didn't do straight sticks. And, my philosophy is, I think it's awesome that, Amy, you do, conventional laparoscopic sacrocolpopexy. Nothing wrong with that. Would I ever convince you to do robotics for that? No. Because you're already doing what you need to be doing. You're doing MIS surgery and you're doing a great job and you get great outcomes. So I don't care. For me, it's like choose your tool that you do best. And I think if we, it's just part of the evolution and that's where things are going. The technology is getting better.
But I'm an economist at heart. We can have opinions and thoughts, but at the end of the day, are people using robots and it's allowing them to do more laparoscopic surgery? It is. And at the end of the day, like Arnie said, the patient is getting a minimally invasive surgery, and they're likely getting less or more minimally invasive surgeries or having more exposure to that option because more surgeons feel comfortable doing minimally invasive surgery with the robot.
I just want to ask you, because we are at a pivotal point in history for complex gynecologic surgery. And as a urogynecologist and ally, I just want to get your perspective on the field. Like, where are we going? What's the latest status? How do you see the field evolving? Are you guys going to get board approval from ABOG? Like, what's the future?
I'm a glass half full guy. I think the future is bright. As many of you may or may not know, it started a year ago while I was president of the FMIX board that we started the process of trying to obtain subspecialty recognition, as an ACGME accredited fellowship. And it's been moving along, albeit slow. But yeah, as you can imagine, to carve out a niche of that subject matter based in complex benign gynecology is not going to be an easy lift, right? Because, we are the one area that kind of overlaps a little bit with what the general OBGYN does and what some of the other subspecialties represent. And so it's really all about making sure that we are clearly defining so that other people understand what it is that we do. Because I think many of folks, you guys are in institutions where you have people that are doing the kind of work that complex benign GYN surgeons do. It fills a big void that complements the other subspecialties and the generalists, the specialist OBGYNs. And so it's going to happen. I'm very confident that it will. It's just going to take time, and we've got to, really work together with all the stakeholders, GYN oncologists, urogynecologists, the REIs, the general practicing full scope OBGYNs, to make sure that they understand that we're not here to say we're taking over, everything. It's really being here to take over that higher level of complexity, right? Like, I don't want to see every AUB patient, every endometriosis patient, every fibroid patient, but I think we all appreciate that there comes a time where there's a break point where, you really do need that subspecialist that can do the multidisciplinary care coordination for that complicated endometriosis surgery. I have a case tomorrow, tripartite case. It's going to be myself, a thoracic surgeon, and a hepatobiliary surgeon, right? Because that's the kind of level of endometriosis has become invasive in this patient. That's not something that an average practicing OBGYN is going to be care coordinating and putting all this effort into. That's really the level that you need the complex benign gynecologist to come into, and then to complement the other subspecialists. So there's definitely a place. It's been a big haul to a lift to kind of really kind of pull everything together in a way that makes sense. We're not a procedurally focused fellowship anymore. It's not about MIGS. Everybody does MIGS. That's a philosophy of surgery. You can be open and be a MIGS surgeon philosophically, how you're going to approach that open case. So it's really about, if you're the expert on fibroids, like, you have to know how to do open surgery, hysteroscopic, laparoscopic. If you're using a robot, then it's a robot. But that's really where I think it's going, Amy, to answer your question. I'm excited about the opportunity that this will bring to women's health. It needs to happen. It's going to elevate the care of women. There's no doubt in my mind. And we just have to keep the foot on the pedal and just see it through. It's going to take a few years. I'm not naive about that, but anything worth doing is going to take time and effort. And this is 100% worth doing.
Well, I have no doubt, Arnie, that if anyone can do it, if anyone can be a part of something like that, it's you. I just wanted to take a moment or two at the end to recognize you and your mentorship. You've said it a few times in different ways in the show, a high tide floats all boats. And how do we bring everybody up? And we talked about the number of people you've mentored. And again, I didn't train with you, but you've always taken time to pull me aside and say, hey, how are things going? And, you're a busy guy. I don't know, if there's a such thing as a medical celebrity, Arnie, I think you qualify.
I don't think so.
I saw him at the end of the meeting in Vegas, and he was like, oh, I didn't know you were here. I was like, well, I was waiting for the line to get, to dwindle down a little bit, the line to go greet Arnie, because you're someone that means a lot to a lot of people, which is a testament to your...
Well, I appreciate the compliment.
Well, it's true that your effort to not just be a pioneer, right? Because there's a way to do that and focus on you, but you haven't done this alone. You've done this and brought dozens and dozens and dozens of people along who've brought on other people, and you've taught a way to be a pioneer but lead other people along. And so it's been fun for me to sort of see you early on from afar and to be able to benefit from the work you did in Ann Arbor, and to be able to continue to benefit from your mentorship. And it's been a fun thing to get to know you and to become friends along the way. And so I'm grateful that you have done all you've done, but also that you've been a friend and agreed to join us on the show. We really appreciate it.
Oh, real honor, honestly. It's what a pleasure to be on the show with the two of you. This is an amazing podcast that you guys run. It's just fun to be able to get up here and just be kind of strip down and, just say what it is, right? It's awesome. So I really appreciate that.
Thanks, Arnie. You've always been like such a great support over the years. And I think under your stewardship, I saw what's happened with robotic surgery, and then stewarding this process, I think I'm sure it's a learning curve to it, but best of luck.
Thanks.
I don't have incentive to it, but I do think it's looking pretty bright. I don't know all the hurdles that you have to jump. I think it's a lot of bureaucratic hurdles, but hopefully you can get it done.
Well, focusing on the pathology, and that's what John Delancey said, right? It's like, it's not about technique, it's about the disease, and fibroids and advanced endometriosis and chronic pelvic pain are things that not everybody has the sort of interest and focus in their career and practice and skill set to manage those complex, very complex at times diseases. And so I think that's been the focus of most of our clinical practices, and I think that'll be where this ends up. And I'm happy that it's getting the recognition that it deserves. Our patients deserve it.
Yeah. Let's see where we are a year from now.
We'll have you back on to tell us all about it. So thanks again, Arnie.
Yeah, absolutely.
Have a great night.
Thank you.
Yeah. Thanks so much, guys.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bove, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Yvonne Orgoginski.
Show notes and social media by Emma Landenwich
and Lindsay Beecham.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.